Hi, my name is Callie Seals and we're from Auburn University Harrison College of Pharmacy. We're going to be talking about extracorporeal membrane oxygenation, or ECMO. ECMO is a life support machine that is used for those who have severe and life-threatening illness that stops their heart or lungs from working properly. And here's an image of what the circuit can look like. ECMO is going to serve as a heart and lung bypass through an external pump, oxygenator, and heat exchanger. This is a supportive measure while treating an underlying disease or injury or until organs for transplant become available. There are two types of ECMO, veno-venous and veno-arterial, and the method selected will depend on the support that the patient requires. For veno-venous ECMO, patients are going to be requiring pulmonary support. They will undergo cannulation either at a single or dual site, where blood will be removed via a large vein, and undergo external circulation, where the blender will deliver oxygen and the sweep gas will remove carbon dioxide. The blood will then be warmed and returned via the vein. And here's an example of what the veno-venous circuit looks like. The veno-arterial ECMO is for patients requiring full cardiopulmonary support. They will have cannulation via a vein and an artery. The blood will leave through the vein and undergo external circulation, where it will help support cardiac output, bypass the cardiovascular system, and decrease cardiac work and oxygen demand. The blood will then be returned via an artery. And here's an example of what the veno-arterial ECMO circuit can look like. Common indications for neonates can include persistent pulmonary hypertension, congenital diaphragmatic hernia, meconium aspiration, and for children, it can be pulmonary infection, with viral pneumonia being the most common cause of hypoxic respiratory failure requiring ECMO. And there's also aspiration and acute respiratory distress syndrome. Criteria for neonates is going to include gestational age greater than or equal to 34 weeks, a weight of approximately 2 kilograms, and a presence of reversible process. They need to have an absence of lethal anomalies, uncorrectable defects, coagulopathies, or major intracranial hemorrhage. They also need to have failed optimal medical management that includes maximal pharmacologic support, oscillator, and nitric oxide. The weight requirement is determined by the lack of a smaller cannula and the resultant flow limitations of such a small catheter. Contraindications, there are absolute ones and relative ones that are listed here. So ECMO should not be initiated in these patients because it is likely to be futile. In high-risk patients, they generally have poor outcomes with ECMO, but are not necessarily contraindicated. These patients will include those with pertussis pneumonia or disseminated herpes simplex, cytomegalovirus, severe multi-organ failure, or severe coagulopathy or thrombocytopenia. And here's a graphic summarizing indications, contraindications, and modes of support from the Extracorporeal Life Support Organization, or ELSO, from their guidelines for neonatal respiratory support. There are several complications that can come with ECMO. And so with cannulation, you can have bleeding, vessel damage, air embolism, and several other things. You can also have neurodevelopmental abnormalities, kidney failure, infection, leg damage, and stroke. So there are many systems involved with ECMO and many that are affected. And there are several changes and things that need to be anticipated and managed proactively to maximize positive outcomes. So the cardiovascular system is supported by ECMO, and intravascular volume should be maintained. And there also may need to be inotropes used to help improve cardiac output. With the respiratory system, the amount of support is going to depend on the type of ECMO used. So like we mentioned earlier, veno-arterial ECMO is going to have minimal flow involving the pulmonary circuit, while veno-venous ECMO is really going to affect that a lot more and require more adjustments throughout treatment. And here's another image from ELSO that summarizes kind of the ventilation settings, and settings at rest are in that red box if you're interested. So the central nervous system, it's going to require a lot of frequent assessment to identify any changes in mental status or seizures, and may need some cranial ultrasounds. There's a lot of neurologic complications with increased mortality in ECMO, especially with veno-arterial ECMO. And neonates have a really high risk of long-term complications like intraventricular hemorrhage or neurologic infarction. With the hematologic system, ECMO is going to, again, act as a large non-biological circuit and is going to trigger an inflammatory response. So you can have thrombosis that will require continuous infusion of heparin, and you may also need some fresh frozen plasma or recombinant antithrombin. And monitoring should include a CBC and activated clotting time. And again, here's another summary from ELSO, just looking at, some monitoring parameters and things relating to hematologic system. So with the renal system, there's that inflammatory cascade going on that can really impact the kidneys. You can have the issues with oliguric acute tubular necrosis, and there's going to be a lot of supportive measures with diuretics, hemofiltration, and potentially dialysis. There are also going to be some difficulties with fluid and electrolyte management. There can be some high sodium due to volume expansion and blood products, and you can also have some high extracellular potassium from hemolysis and low calcium due to citrate binding from blood products. For the GI and fluid electrolytes and nutrition, many patients are going to require total parenteral nutrition or TPN early on. There is a concern with lipids. Intravenous fat emulsions can actually have a procoagulant activity in the ECMO circuit. And so lipids need to be administered via a separate IV site and should be dosed at 0.5 to 1.5 grams per kilo per day. And some institutions do utilize enteral feeds to help with the risks associated with TPNs, like infection and increased bilirubin levels. Regarding the immune system, we had mentioned the inflammatory cascade that's going on. So this can make fever a little bit more unreliable due to the normothermia from the heater associated with the circuit, and leukocytosis can also increase white blood cells. So there's going to be some difficulties ensuring the lack of infection and monitoring appropriately for those. And expert panels have recommended liberal use of diagnostic tests and cultures, since utility does not always outweigh costs until later on in therapy. So there are several pharmacokinetic changes that happen whenever we start ECMO. With absorption, we're going to have unreliable absorption with oral administration, and the majority of medications will be given IV. In terms of distribution, there is going to be lipophilic binding to the circuit surfaces and an increased volume of distribution from hemodilution, increased protein concentrations with increased ECMO duration. So this may increase the free fraction of highly protein-bound medications. There's going to be reduced hepatic metabolism and decreased metabolic capability due to organ hypoperfusion. There will also be impaired renal excretion due to stimulation of arachidonic acid and renin from that inflammatory cascade, and a decrease in renal blood flow and overall renal excretory capacity. So with all these physiological changes that are happening to our organ systems, that we're going to have some pharmacologic challenges. There's also the lack of literature about medication dosing during ECMO, and then the properties of the circuit itself can lead to several challenges. The physical composition of the circuit and oxygenator, the pump, and the age of the circuit can all influence medications. The higher the lipophilicity of a medication, the more likely it will be to adhere to the ECMO circuitry and become less available to the patient. So we're going to talk about a couple of specific categories of medications that can be especially difficult. So with anti-infectives, we have gentamicin, one of our concentration-dependent antibiotics. It's going to have an increased volume of distribution and a decreased renal clearance, so we're going to need to monitor peaks and troughs. With vancomycin, our time-dependent antibiotic, we're going to need to continue to monitor troughs. Cefotaxime did demonstrate increased volume of distribution without a decrease in clearance, and standard dosing was appropriate. With fluconazole, we had an increased volume of distribution without major changes in clearance. It does lack a lipophilic profile, so it is a good antifungal during ECMO. With meropenem, it is unstable in warmer temperatures, so the ECMO here may reduce the efficacy of it. However, there was clinical success shown in one study when it was delivered via continuous infusion. With oseltamivir, it showed decreased total plasma concentrations, so it required doubling the age-specific dosing. With sedatives, we have midazolam. It is highly lipophilic and highly protein-bound. It also has 3A4 metabolism, so the active metabolite is going to be prolonged. It can have a 3 to 4-fold increase in volume of distribution with variable clearance in Ecmo patients, so careful monitoring is going to be required. Lorazepam has a lack of an active metabolite and poor solubility in water, and the vehicle required to solubilize the drug, polyethylene glycol and propylene glycol, are going to, that can lead to anion gap acidosis as it accumulates. So just some careful monitoring with these sedatives. With our opioids, fentanyl is going to have extensive circuit sequestration and can cause clinical failure. We can also have tachyphylaxis and require very delicate dosing. And with our morphine, it's actually the preferred opioid in ECMO as it undergoes glucuronidation to an active metabolite, but it can still have accumulation that can occur during critical illness and ECMO therapy. So in conclusion, ECMO, or extracorporeal membrane oxygenation, can be utilized via the veno-venous access to allow for pulmonary healing or veno-arterial access to bridge therapy until cardiac repair. There are many organ systems impacted by the presence of this exogenous non-biological circuit, and proactive management is necessary. Critical illness and the presence of the ECMO circuit can alter medication kinetics, efficacy, and safety, and increased monitoring is going to be very important here. Thank you for your time, and please let me know if you have any questions.